All right, welcome to the deep dive. Today we're tackling something that definitely sounds a bit alarming. Coughing up blood, or haemoptysis, as we call it medically.
Hmm.
We've gathered a whole load of notes, all focused on helping you, our listeners, getting ready for the MSRA, really get a grip on this topic.
Yeah, absolutely.
Our aim is simple. Give you a solid understanding of haemoptysis, what it is, what causes it, how it's managed, and hopefully in a way that makes it stick.
Exactly. And we'll throw in some memory aids, maybe a few practice questions too, just
Yeah.
to cement the knowledge.
Perfect. So
Yeah,
ready to jump in?
let's do it.
Yeah.
So first things first, what is haemoptysis? Well, fundamentally, it's coughing up blood that's coming from the respiratory tract below the larynx, the voice box.
Okay, so below the voice box, we're talking lower airways.
Precisely. Lower airways, trachea, bronchi, the lungs themselves. And, one of the very first things you need to do is differentiate it from other things that look similar.
Right, the lookalikes. Always tricky. What are we differentiating it from?
Okay, so first up is Haematemesis. That's vomiting blood. Completely different origins coming from the GI tract.
Ah, like stomach ulcers, that kind of thing.
Exactly. Stomach ulcers, esophageal varices, and the blood might even look different, maybe darker, kind of like coffee grounds because of the stomach acid.
Gotcha. Vomiting blood, haematemesis. What else?
And there's epistaxis. That's just a fancy word for a nosebleed.
Okay.
But sometimes, if you have a nosebleed, the blood can drip down the back of your throat into the pharynx, and then you cough it up. So it looks like haemoptysis, but it isn't.
Right, so you need to check the nose, too. Makes sense.
Any others? One more main one, pseudo-haemoptysis. Pseudo meaning false, right?
Hmm.
So this is blood that is coughed up, but it's actually coming from somewhere like the mouth, the gums, the throat, basically the upper airways above the larynx, not the deep stuff.
Okay, so really nailing down the source is step one. Lungs down, haemoptysis. Stomach haemoptysis, nose epistaxis, mouth upper throat is pseudo-haemoptysis.
You've got it. That distinction is critical.
So, focusing on true haemoptysis then, from the lungs down, what actually causes it? I imagine there are quite a few possibilities.
Oh, yeah. The list is pretty long, which is why it helps to sort of categorize them. Sometimes, actually, we don't find a specific cause that's called idiopathic haemoptysis,
Right?
but usually we can slot the causes into a few main buckets. Respiratory or lung disease is a big one, then cardiovascular problems, coagulation disorders, and finally, trauma.
Right. Let's break those down. Respiratory causes first. What kind of things are we talking about there?
Okay, so infections are really common here. Think pneumonia, tuberculosis, TB is a classic cause, definitely one for exams, lung abscesses, even just really bad bronchitis.
Oh, infections.
Then you've got structural lung problems, like bronchiectasis. That's where the airways are abnormally widened and damaged, making them prone to bleeding.
Okay.
And of course, a really serious category is malignancy.
Hmm.
Cancers,
So?
lung cancer, bronchial cancer, even laryngeal cancer sometimes.
Right, cancer is always on the list. Anything else in respiratory?
Yeah, one more to mention is pulmonary embolism, a PE. While chest pain and shortness of breath are more classic, haemoptysis can happen.
Interesting. Okay, that's a fair few lung issues. What about the cardiovascular causes? How does the heart or blood vessels lead to coughing up blood?
It's usually about pressure changes in the lungs' blood vessels. So pulmonary edema, fluid on the lungs, often from heart failure that can cause it.
Yeah, increased pressure.
Exactly. And much rarer, but very serious, is something like a ruptured aortic aneurysm that creates a connection with a bronchus, an aortobronchial fistula. Massive bleed risk there.
Wow. Okay.
And just congestive heart failure itself, by causing that backup of pressure, can sometimes contribute too.
So pressure and sometimes these weird connections. Got it.
Oh.
Next category was coagulation disorders. So problems with blood clotting.
Spot on. This covers inherited conditions, like Christmas disease or hemophilia A and B, where the blood just doesn't clot properly from birth. But it also includes acquired clotting problems, maybe from liver disease or certain medications. Anticoagulants are a big one here.
Okay.
And also things like vasculitis, inflammation of the blood vessels.
Okay, so inherited, acquired, or medication-related clotting issues. And the last category was trauma.
Yeah, trauma. Pretty straightforward, really.
Yeah.
A penetrating injury to the chest, like a stab wound, or significant blunt trauma, like in a car crash.
Makes sense.
Direct injury to the major airways, the bronchi, can cause bleeding too. And maybe less obvious, but important, especially in kids, is aspirating a foreign body. Swallowing something that goes down the wrong way and injures the airway lining.
Right, foreign bodies. Good point. Okay, that's a lot of causes. Is there a trick to remembering those main groups?
There is. We came up with a mnemonic I really can't cough properly today.
Okay.
I for idiopathic, R for respiratory, C for cardiovascular, the second C for coagulation, P is skipped, T for trauma. I really can't cough properly today.
I like it. I really can't cough properly today. Idiopathic, respiratory, cardiovascular, coagulation, trauma. Brilliant. Okay, so now we know the causes. Who's actually more likely to get haemoptysis? What are the key risk factors?
Well, smoking is a huge one, especially if someone already has COPD or obviously lung cancer. That's probably top of the list.
No surprise there.
Exposure to certain things in the environment, toxins like asbestos or silica dust, they cause chronic lung damage.
Right, occupational exposure.
Definitely. Also, having a history of chronic lung infections or inflammatory conditions, think chronic bronchitis, cystic fibrosis, even bronchiectasis again.
So ongoing lung irritation or damage.
Exactly. And a past history of blood clots, like a pulmonary embolism or a DVT, deep vein thrombosis, that increases risk too.
Okay.
And we have to mention again, because it's so important, underlying problems of blood clotting or being on anticoagulant therapy like warfarin or heparin, that significantly bumps up the risk.
Yeah, that's come up a few times now. The anticoagulants and coagulopathies, definitely key. Okay, quick scenario for you then. Testing those risk factors.
Go for it.
A non-smoking 25-year-old presents with haemoptysis. Which of these is least likely to be a significant risk factor for them? A, smoking history, B, exposure to asbestos, C, history of DVT, or D, underlying coagulopathy?
Okay, well, the question states they're a non-smoker. So, A, smoking history is definitely the least likely significant risk factor in this specific patient.
Perfect, exactly. Okay, let's dig a bit deeper into the pathophysiology. What's actually happening at the biological level when someone coughs up blood?
So fundamentally, it boils down to a disruption of the blood vessels in the lungs or airways, the pulmonary vasculature. Something damages these vessels, causing blood to leak out into the airways, and then it gets coughed up.
And what kind of things cause that damage?
It links back to the causes we talked about. Inflammation from infections or other conditions can make vessel walls weak. Infections themselves can directly eat away at tissues and vessels. Trauma obviously causes direct physical damage. Tumors can grow into blood vessels and erode them. And in some chronic diseases, the vessels just become fragile over time.
Right.
And the key thing clinically is that the amount of bleeding can be tiny, just streaks in the sputum, or it can be absolutely massive, a life-threatening hemorrhage. The volume varies hugely.
Okay, so vessel damage is the core issue. Now, we touched on the differential diagnosis earlier, haematemesis, epistaxis, pseudo-haemoptysis. How do we really lock down the difference in practice?
It really comes down to careful history-taking and examination. With haematemesis, ask about vomiting, nausea, abdominal pain. Look at the blood. Is it dark, coffee grounds?
Right, clues from the GI system.
Exactly. For epistaxis, have a good look up the nose. Usually you can see the bleeding source. Or the patient might report recent nosebleeds.
Makes sense.
And for pseudo-haemoptysis, examine the mouth and throat carefully. Are there bleeding gums? Maybe a lesion in the mouth? Is the blood appearing without a forceful cough from deep down?
So it's about connecting the dots, the story, the appearance, and what you find on examination. Any quick memory tip here?
Just think. Origin, lungs, haemoptysis, stomach, haematemesis, nose, epistaxis, mouth or upper throat, pseudo-haemoptysis. Focus on the origin.
Origin. Got it. What about epidemiology? Is haemoptysis common? Who gets it most?
Its prevalence really depends on what underlying causes are common in a particular population. But generally speaking, it's seen more often in adults than kids.
Okay.
And there's that strong link we mentioned with smoking and chronic lung diseases like COPD and bronchiectasis. So populations with higher rates of smoking will likely see more haemoptysis.
And things like TB rates matter too, I guess.
Absolutely. In areas where TB is endemic, it'll be a much more common cause, and therefore you might see more haemoptysis overall.
Right. So let's imagine a patient walks in. What's the typical clinical presentation? What symptoms might they have apart from the blood?
Well, the main thing is the coughing up of blood. But as we said, the amount varies massively, from just flecks or streaks in the sputum to cupfuls of bright red blood.
Okay.
Alongside that, they might have the cough itself, obviously.
Yeah.
Chest pain is common, shortness of breath, or dyspnea, maybe some wheezing. And depending on the cause, you might get systemic symptoms too, things like fever, chills, night sweats, unexplained weight loss. Think infections or malignancy there.
So the whole clinical picture matters, not just the blood.
Definitely. How severe it is, how long it's been going on, the other symptoms, they all give clues to the underlying cause and how urgently you need to act.
Okay, let's try another quick case. A patient with a chronic cough suddenly develops blood-streaked sputum and reports having night sweats recently. Which cause is most likely? A, simple bronchitis, B,
Okay.
pulmonary embolism, C, tuberculosis, D, GERD.
Right. Chronic cough, blood-streaked sputum, and night sweats. That combination really points towards tuberculosis C. Night sweats are a big red flag for TB.
Exactly, good pickup. So when a patient presents like this and we suspect haemoptysis, what investigations do we typically order?
It's a fairly standard workup, aiming to find the cause and assess the severity.
Right.
You'd start with blood tests,
Right.
full blood count, check hemoglobin, platelets, coagulation screen vital to check clotting, UNEs and LFTs for general organ function, and a group and save, just in case they need blood.
Right. Baseline bloods and clotting.
Yep. If their oxygen sats are low, you'll want an arterial blood gas, an ABG. Other labs might include sputum tests, looking for bacteria like TB or maybe malignant cells, sometimes tumor markers, depending on the suspicion.
Okay, bloods and sputum. What about looking at the lungs?
Imaging is key. Usually start with a chest x-ray, gives you a good overview look for masses, infiltrates, fluid.
Standard first step.
But often you need more detail. So a chest CT scan is very common. High-resolution CT gives great detail of the lung tissue itself. A CT pulmonary angiogram is brilliant for looking at the blood vessels, checking for PEs or other vascular issues.
So CT gives a much closer look.
Definitely. And then, for a direct look inside the airways, there's bronchoscopy, passing a flexible camera down into the trachea and bronchi.
And you can take samples with that?
Exactly. You can see where the bleeding might be coming from, and you can take biopsies of suspicious areas or washings for culture.
Okay, that sounds pretty comprehensive. Any way to remember those main investigation types?
How about blood picture for all the blood tests, then picture the lungs for the X-ray and CT, and finally a peek inside for the bronchoscopy.
Blood picture, peek. I like it. Simple and covers the bases. So once we've done the investigations, how do we actually manage haemoptysis? What's the treatment approach?
Well, the number one thing is to treat the underlying cause, whatever that turns out to be. If it's an infection, give antibiotics. If it's related to anticoagulants, maybe adjust or reverse them. If it's a tumor, oncology referral.
Treat the cause. Makes sense. What about managing the bleeding itself?
Yeah, there's supportive care first, bed rest, often positioning the patient with the bleeding side down if known. Supplemental oxygen if they're hypoxic, helping them clear their airways gently.
Okay.
Medication-wise, besides treating the cause, you might use bronchodilators if there's bronchospasm. In some situations, antifibrinolytic drugs like tranexamic acid might be tried to help reduce bleeding, though evidence varies.
Right.
For more severe ongoing bleeding, we might need interventional procedures. Bronchial artery embolization is a key one, where interventional radiologists selectively block the artery supplying the bleeding site.
Blocking the type.
Pretty much. Or sometimes actual surgery might be needed to remove the affected part of the lung, especially for massive bleeding or certain tumors.
Okay. And what about someone who comes in with massive, life-threatening bleeding right now?
That's an emergency. You go straight to the ABC approach. Airway first, make sure it's clear, suction ready. Consider intubation early if they're unstable or bleeding heavily to protect the airway.
Hey, airway. Got it.
B, breathing. High flow oxygen. Aim for SATs, 94-98%. Support their ventilation if needed, especially if intubated.
B, breathing.
C, circulation. Get large bore IV access immediately. Start 4V fluids. Check bloods urgently, cross-match blood, and transfuse blood products as needed. If it's a crash situation, you might use O-negative emergency blood.
C, circulation. ABCs. As always, in an emergency.
Always. Stabilize first, then investigate and target the cause.
Okay, that's a clear management plan. What about the prognosis? What's the outlook for someone who's had haemoptysis?
It's really variable. It completely depends on the underlying cause, how bad the bleeding was, and how well they respond to the treatment.
So no single answer.
No. Mild cases, maybe from bronchitis, might clear up completely on their own or with simple treatment. But severe or recurrent bleeding often points to something more serious, like cancer or advanced bronchiectasis, and the prognosis there is naturally poorer. Early diagnosis and treatment are key.
Right. And finally, what are the potential complications we need to worry about with haemoptysis?
The big immediate risks are related to the bleeding itself and breathing. Hypoxia, low oxygen levels, is a major concern if blood fills the airways.
Okay, hypoxia.
That can lead to respiratory compromise or even respiratory failure if severe. If the blood loss is significant, you can get hemodynamic instability, low blood pressure, shock.
So breathing problems and circulation problems.
Exactly. And another risk is aspiration pneumonia, Inhaling blood into other parts of the lung can set off an infection later.
Right, aspiration.
And of course, the most severe complication of massive haemoptysis is, unfortunately, death if it can't be controlled quickly enough.
Serious stuff. Is there a quick way to remember those main complications?
We could use the batty H's, B for breathing problems, respiratory compromise failure, A for aspiration pneumonia, D for decreased oxygen, hypoxia, and H for hemodynamic instability.
The BADHs. Breathing, aspiration, decreased oxygen, hemodynamic instability. Another good one.
Hopefully useful.
Definitely. Well, that was certainly a thorough deep dive into haemoptysis. We've gone through the definition, the causes using I really can't cough properly today, the risk factors, how it happens, how to tell it apart from other things.
Plus the investigations, blood picture, peak the management, including the ABCs, and the prognosis and complications with the B8H's.
Yeah, covered a lot of ground. Hopefully that's given you listening a really solid, clear overview for your MSRA revision.
Absolutely. And, thinking about all those varied causes, it does make you wonder what seemingly unrelated symptoms might actually make you pause and think, could haemoptysis be part of this picture?
Ooh, that's a great question to leave people chewing on. A real clinical pearl to consider.
Food for thought.
Definitely. Well, for more MSRA revision help, don't forget to check out passmsra.com and also freemsra.com. Loads of resources there.
Great sites.
Thanks so much for joining us for this deep dive into haemoptysis today.